Can everybody see that okay?
Yes, ma'am, we can. Thank you.
But I'm going to talk specifically about the stigma of addiction or substance use disorders, both by and against patients and providers, because when we think about building a workforce, this not only affects patients, but it affects us in the ways that individuals who work with patients with substance use disorders actually get stigmatized, as well as can be the perpetrators of stigma against patients. And so it's interesting to think about all the different angles that stigma gets expressed. So just today we'll talk about what stigma is, who's stigmatized, who's responsible, how it impacts both patients and providers, and the research, and how we can work to reduce it, and that we can all really play an active role in reducing stigma of substance use disorders. So generally, stigma is conceptualized as like an attitude, behavior, or condition that is socially discrediting. So people are made to feel less than, excluded, and not worthy. And this can happen in a variety of different levels. So public stigma, we typically think of like institutional stigma, so at a hospital level, or religious institutions, or commercial media certainly can be involved in either working to reduce or perpetrating stigma. Private level, which can be more community-based, families both deal with being stigmatized as well as stigmatizing their loved ones with substance use disorders. And then personal stigma. Personal stigma is typically related to our own personal experience with substance use disorders, or the people that we love who may struggle with substance use disorders, and is really heavily impacted by their success in recovery. It will really influence the ways that people feel about individuals with substance use disorders, and having hope that people can get better. So there's a lot of research in this area, so I'm going to kind of sprinkle that throughout. But Room did a study looking at the different kinds of disorders that are stigmatized. So obesity is certainly stigmatized, and you know, diabetes can be stigmatized, type 2 diabetes more so than type 1. Whenever there's blame and a behavioral component to a disorder, it is typically more stigmatized. But substance use disorders is among the most stigmatized mental health condition, even more so than things like schizophrenia. So they did these polls with people and basically elicited what they thought were the worst disorders, and individuals with substance use disorders were the most stigmatized. And I always like to just touch on where this comes from, because the United States is typically more stigmatizing of substance use disorders than some other countries. And we have had a very long history of criminalization of substance use disorders. It actually started before the 1900s with the temperance movements, which were really in the 1800s, which were this sort of social movement of initially moderation and then abstinence of all substances. And if you were not able to be abstinent or moderate your substance use, you were morally weak. So that started with sort of the moral judgment. And then it moved into the political arena of really being criminalized. And in fact, people who prescribed treatments for opioid use disorder were criminalized. So this, the Harrison Act of 1914 basically criminalized what we now think of as medication for opioid use disorder. And then people were familiar with prohibition. So alcohol use became criminalized, and there was this real like clamp down, moral failing, people who use substances are bad people that went on in the beginning of the 19th century. And then that was repealed in 1933, but it kind of stuck with this widely held belief that people who use substances or struggled with substances were weak and morally inept. And also during this time, treatment really became separate from treatment for other medical disorders. And so people were put in different places in the healthcare system, separate from individuals with medical illnesses. And so that was also stigmatizing. We then saw some of us are alive for some of these. Nixon deemed substances or drugs public enemy #1. And so when you think about that, well, what does that say about people who use substances? It means they, are also the enemy, and we are all fighting against them. So it puts them in a very discriminated position. Reagan and his war on drugs criminalized addiction very clearly. And when you look at the amount of people who have been incarcerated for drug-related offenses, it really just, as a result of these political movements, ballooned. And so about 80% of individuals are incarcerated for nonviolent drug-related crimes. So that's where it comes from, kind of a almost 200-year history of people who use drugs are bad kind of message. And then in the world of addiction, this is who is stigmatized. Individuals with substance use disorders, certainly people of color are even more stigmatized than Caucasian individuals, people who do not fit into kind of a binary kind of sexual identity. So LGBTQ community is stigmatized more highly than straight folks, and families with a loved one with a substance use disorder are often stigmatized in their own community. There's a kind of shunned, we're not going to talk to them. Parents get blamed for their loved one's substance use disorder. And we know that people on medication-assisted treatment are stigmatized, even by the recovery community. And then we as providers are also stigmatized. I'm going to solicit some personal experience with that later, but so think about whether you have ever felt stigmatized by your own family or professional colleagues for the work you do with individuals with substance use disorders. And who's responsible? Like we all are, really. We see this, patients stigmatize one another, people in recovery stigmatize one another, so there's sort of a hierarchy of badness. If you use substances IV, you are worse than if you take substances by mouth. There's this hierarchy of moral failing. Doctors certainly stigmatize patients with substance use disorders, nurses, therapists, families, pharmacists, the criminal justice system, and we also see it among child protective services workers. And this is a nice graphic just about the cycle. And so when we think about, first the person gets labeled, like how does this go? Although you can enter into this cycle in any place, but people label another as other, as less than, as different. And then that label is associated with some kind of negative stereotype. And it takes on kind of a preconceived image of what does that label mean? So addict being a stigmatizing label as an example. And there's sense that person is not like me. There's a division, us versus them. I don't want to be with that person's dirty, or that person is somehow unacceptable socially. And then the person loses social status, and with that can lose kind of all kinds of status with regard to, workplace, certainly housing. Discrimination comes in when people are discriminated against for having substance use disorders, and that means they don't have access to housing or other kinds of healthcare, anything that people can get basically shut out of. And then it continues in this vicious cycle and gets pretty ugly. So why does it matter? So I talk about stigma most chances that I get. It matters essentially because it affects millions and millions of people. And I would suggest that the primary barrier to people getting treatment and to people being interested in treating people with substance use disorders is stigma. So these are just some numbers about 3.3 million people a year die of alcohol use disorder. We often don't talk about that, but many more people die of alcohol use disorder than opioid use disorder. It just takes longer typically to kill someone. And 350,000 people die from illicit drugs. You guys probably know the numbers in 2020 with regard to opioid use disorder. last count I saw was it's about over 93,000 people died of overdoses, and the vast majority of those were opioids, and 60% of those were synthetic opioids, and that was up from about 70,000 people in 2019. So COVID had a very negative impact on the folks that we try and help. So in general, 23 million people with a substance use disorder, and kind of the cost is huge in terms of productivity, criminal justice system, healthcare costs. And people have some access to treatment, not enough access. And even when people have access to treatment, they don't seek treatment. And this is in large part because of stigma. So there's been lots of research in this area, looking both at kind of the public as well as healthcare providers. So this study, looking at over 3,000 respondents, basically just asked people to read certain vignettes, and this was a public sample, so the sample of just the general public, different vignettes about people with mental illnesses versus people with substance use disorders. And people with substance use disorders were much more highly stigmatized than those with mental health struggles. And however, the positive news was people who had received, if the vignette was about someone receiving treatment, there was slightly less stigma. So that was actually a positive finding from the study. This was another study that looked at individuals receiving treatment for substance use disorder. Specifically, their primary drug of choice was heroin. And they talked about being discriminated against because of their substance use disorder. They felt other people feared them. And they also felt abandoned by their family. So that was some of the ways that they experienced stigma. And this actually impacts people's retention and treatment, as if they feel stigmatized by their healthcare providers, they are less likely to be retained in treatment. So in terms of stigmatization by healthcare professionals or other kinds of professionals, pretty disturbing research showing that patients with substance use disorders are held in pretty poor regard by their providers, experiencing them as unmotivated, violent, manipulative, and that they don't really want to work with them, so they don't probably spend as much time in the office setting with them, or they may dismiss them very quickly from care, just to sort of not be around them, which is really disturbing. In 2016, Kennedy Hendricks, she does a lot of research in this area, did a study of primary care physicians who showed as high or higher rates of stigma than the general public towards individuals with substance use disorders. And again, many people with substance use disorders do seek care from their primary care physicians, so this is pretty disturbing. And the stigmatizing attitude towards people with opioid disorder was also found in professionals in all kinds of settings, including public safety, criminal justice, housing, welfare, which just means there's likely discrimination in those areas as well. In 2016, the national survey reported more than 3/4 of people viewing individuals with opioid use disorder as literally to blame for their substance. So we often get into that debate about choice versus disease. I run a multifamily group as part of our IOP program, and we always present this to the family members, is addiction a choice or a disease? When we think of it as a choice, then you're essentially blaming people for making bad choices. Nearly 3/4 of respondents in this study characterized people with opioid use disorders lacking self-discipline, and that they didn't want their loved one to be involved in, say they didn't want their daughter to marry someone with a substance use disorder, and endorse discriminatory measures like denying people employment because they had a history of substance use disorder. And so this is some of the ways that it all plays out in various settings. And many of you guys, I would think, have your own experiences of stigma towards medication for opioid use disorder. And so whether that's being stigmatized as a provider, a person treating someone in a setting where medications are prescribed for opioid use disorder, or the patients talk about being stigmatized for being on medication. But there have been lots of studies in specifically looking at this kinds of discrimination and stigmatization also. So I always like to share a little bit of good news, which is Cindy Parks Thomas did some research, and we've actually seen this as we have expanded medication-assisted treatment around West Virginia, that clinicians actually, when they have a little bit of experience prescribing with patients, and even when we would have visitors come to the clinic and observe patients, this tends to decrease stigmatization of patients in general who have substance use disorders, as well as the role of medication in the effective treatment of opioid use disorder. So that's why experiential learning, we've tried to integrate a lot of that into our setting with all kinds of disciplines. So counseling students, social work students, nursing students, med students, residents from all kinds of disciplines, because it does seem to really reduce stigma. We've had some great feedback from our nursing students that really say, you know, I thought of substance use this way, and I thought of people who had substance use disorders as this way, and then I came and I sat in your group for 6 weeks, and oh my God, it was totally different than I thought, which is hugely rewarding, and I think good for the healthcare system in general. So the primary effects are stigma becomes a barrier to acknowledging the problem. So people stay in denial longer because they don't want to admit it, because if they admit it, they're going to feel judged or discriminated against. Stigma towards adults with substance use disorders reinforces kind of that misperception about cause and controllability. Like if you really wanted to quit, you would. You just need more motivation, is often what patients will tell me they hear from their families. Individuals with substance use disorders are less likely to seek help due to that perceived stigma. We certainly see this among, say, pregnant women, that they're very fearful of admitting they have a problem for fear of being judged or fear of there being a significant consequence, even though they're presenting seeking help. And individuals with substance use disorder are more likely to drop out of treatment if they feel stigmatized in treatment, and that can be any kind of treatment. So it can be their primary care treatment. They're not going to go to a primary care provider. They're not going to get medical attention if they feel stigmatized. So often we'll hear people have had an experience of being stigmatized in the emergency department, and yet they have a very serious infection. And they're like, I don't want to go to the emergency department. I get treated like crap when I go there. And so this really impairs not only getting treatment for their substance use disorder, but other medical issues as well. And then stigma towards healthcare providers creates a workforce issue in terms of trying to recruit people to work with individuals with substance use disorders. So you guys probably are familiar with the McClellan study, which I talked to you about basically every cycle in my family group. So patients often have this like notion that everybody relapses. So one of the things that stigmatizes substance use disorders is like, well, treatment doesn't really work. Everybody relapses, nobody gets well. So that's a story that gets that infiltrates different communities, and then often patients will believe that themselves. And so this little graph is from the McClellan study that was done in 2000. It really shows that relapse rates among individuals receiving treatment for these different chronic illnesses, drug addiction, diabetes, hypertension, and asthma, have very similar relapse rates. And in fact, substance use disorders is not the highest. Hypertension and asthma have somewhat higher rates than relapse for substance use disorders. And so that's one of the ways that we can combat stigma, is to really present some evidence about not everybody relapses and people do get well, and to be able to share some of those stories of success in the patients that we treat. Language is hugely important, and I'll talk a little bit more about that. So from the kinds of language we put in our progress notes, there's been research to suggest that If you use stigmatizing language in the way that you enter documentation into the medical record, it perpetuates stigma. And if you use non-stigmatizing language, it actually reduces stigma. When the next provider reads your note, they're going to view that patient differently depending on the language that you use. And certainly the language we use to talk with one another or talk with patients about substance use disorders. This belief about cause and controllability is pretty important as it relates to the disease model, or even the learning theory model, that this is kind of a learned behavior, or the disease model. Both models are applicable to substance use disorders. So if you believe that they could quit if they really want to, and it's their fault they got in the predicament anyway of being arrested for whatever behavior may be related to their substance use disorder, that creates a very stigmatizing scenario for a patient. And so combating it, education, personal awareness of your own biases. Again, we all have personal experiences with people, including our patients, in our lives that have struggled and perhaps caused us pain related to substance use disorders. And it's important to kind of be aware of some of those biases while we're treating people with substance use disorders. Generally treating people with compassion and respect is important, which is not always easy. So I work with a lot of the peer recovery coaches in the emergency department. And when people show up to the emergency department, they're often super unpleasant and in a very bad way. So they may be cursing, they may be threatening, they may be very help rejecting. It's hard to treat people with compassion when they are behaving aggressively or like attacking us. So it's not always easy, but if you view someone as having an illness versus being a bad person, it makes it a little bit easier. Person first language. So instead of saying, addict, saying person with a substance use disorder. Instead of saying NAS baby, you can say an infant with neonatal abstinence syndrome. And then that sharing stories of success, you'll hear me say over and over again, which I think we're doing a better job at. I think the media is doing a better job at sharing stories of success versus, the horrific mother found unconscious in, car with infant child, versus like sharing some stories about, mother achieved a year of sobriety and regained custody of her children. So just some examples of language. You can see on the left is the stigmatizing language. It actually took me, since I've been doing this a while, I've been working with individuals with substance use disorders since the early 90s. It took me about a year to stop saying clean and dirty in reference to abstinence and urine drug screens. It took me a really long time. And now I go back and I read some of my progress notes from 5 years ago, and I use that language and I sort of cringe, which means like I've definitely gotten over the hump in terms of what feels normal, but it can take a while to change our language. And usually non-stigmatizing language has more words, so it can feel a little bit inefficient to say person with a substance use disorder versus addict, but it does absolutely make a difference. And it's also more than language. So I love this little this little comment, like just putting a label on everybody that says, oh, you have a brain disease, doesn't always feel good either. And often patients will give me feedback when I begin to talk about, the disease model, that they then feel like, oh, well, there's no hope, because if you have a brain disease, it sounds really, really bad, and like nobody gets better from that. And so it's important to couple it with other kinds of things that are hopeful. So in terms of our own role as healthcare providers, there's lots of things that we can do. We can do things with patients, we can do things with one another, we can do things in our community, but with patients, really helping to reduce that guilt and shame that people have with regard to having a substance use disorder, and then the behaviors that are symptoms. I always sort of put that in context. The bad things that you did when you or active in your addiction are really symptoms of your disease, which doesn't mean they're excused, but it puts them in a context that doesn't necessarily mean you're a terrible person. Support and validation go a really long way. Oftentimes people are not getting that from their families or their communities, especially early on in their recovery. Respecting confidentiality is huge, especially when people are on medication and don't want that shared necessarily with their family. This comes up when women deliver in the hospital and their family may not know that they're on medication. Adopting a non-judgmental stance, treating patients with compassion like any other illness. So any other chronic illness, you should treat patients with substance use disorders the same. And by advocating for patients who voice discrimination. So we've done a lot of that, again, with our pregnant women by trying to educate the nurses in the NICU and the nursing staff on the OB floors about what is addiction, the high correlation between trauma and addiction, especially for women, and the reason that this woman may be behaving like this in the hospital is she's actually having a trauma response, and she has, experienced sexual trauma, and I know she's acting a little bit unusual, but this is not about her trying to make your life difficult as a nurse. And nurses are typically really receptive to that. Once they hear some of the histories of the women that they're working with, they really shift and are much better able to get into compassion. And it's just about asking, the patient a little bit about their story and creating some space for them to tell their story that helps develop that compassion. Then the role of healthcare providers with influencing stigma with coworkers. So whether these are coworkers in other disciplines, so family medicine or neurology or whoever else is working with our patients, educating them about addiction as a brain disease, which people give lots of lip service to, but it's different to really believe it in your head versus believing it in your heart when you're sitting with a patient, is what I've observed. And also sharing stories of success, because oftentimes, again, in the emergency department, they do not see people getting better. They see the same people coming back, and if they don't see the same people coming back, they don't know what happened to them. They may actually be doing really well, but they never see those stories of success. And so sharing some of those can be really important. And then using non-stigmatizing language. And then with ourselves, so being aware of our own biases and finding support for when we really struggle with how hard sometimes this work can be. And so I'm gonna kind of end there and ask a little bit about people's own experiences with stigma and what has worked for you guys to kind of reduce stigma in your various settings. Some of you guys work in different settings that are primarily medical, and what you've kind of done in those settings.
Thank you, as always, Laura. That was a wonderful presentation and a very important one as well. So I'll just reiterate what Laura said. If anyone has any stories they'd like to share, feel free to unmute or chat in. Dr. Houston, I see you unmuted.
I mean, the situations are far too common, of course. Certainly it interfering with people seeking treatment. Like, what always comes to my mind are cases where, actually I've written about this before, but there was one guy who was doing really well, and he had actually had endocarditis and was on medicine and doing fine. And then his peer recovery coach told him to stop the medicine, so that because he was doing wrong. And of course he relapsed and almost died because of that. So that one comes to mind about the stigma that somebody who's already in addiction treatment perpetrated. And then another one, somebody from a recovery service, a nursing one, that they, again, same situation, someone who was stable on medicine for years stable for years on medicine. They do one interview with a coach who immediately said, you need to stop taking medicine, otherwise you're never going to be a nurse. And next thing you know, the guy almost dies. It's shameful when it happens, but it happens all too common. One of the funnier ones that I ever saw was I was speaking to a group of judges, and just the lack of awareness about treatment and what it looks like and how people look and feel on it. I remember one of the questions was, can somebody on Suboxone be a parent? And that was a legitimate question. Like, can somebody actually fulfill the role of parenting? I mean, there's that little awareness of it. So I think there's stigma from just not knowing, so being ignorant, but there's also stigma from just not understanding and kind of basing everything on your own experiences. And again, the people that are well, you're usually not seeing them often, so you get this kind of jaded view of things. And plus, too, if you are in law enforcement, you do see some really just bad characters in general. So that does color their view a little bit differently than somebody who's really working in treatment. But just a few little insights.
Yeah, thanks, Jeremy. And thanks for mentioning, some of the things that we've done to combat stigma. And I'd love to hear what other people have done. Is we had an echo with judges around the state to really teach them about medication-assisted treatment and substance use disorders and the intersection of mental health and substance use disorders and a variety of different topics, and also allowed them to ask questions. And some of the questions were like, no, I had to control my facial expression because it was like, oh my gosh, I can't believe they're asking the question. But like, oh my gosh, they need to ask that question. And how nice to have a forum where they can, because otherwise they're just going to have misinformation. We would love to do this with Child Protective Services workers. We haven't quite gotten there. Well, we tried it a couple of years ago, but the stigma was just really quite overwhelming. They weren't really ready for what we were sharing. So I think we need to go much more slowly with some folks who have an incredibly stigmatizing view. But what are some of the other things that people have done to try and reduce stigma in your community or in your setting? What's worked?
I would like to say that, do you guys hear me okay?
Yeah.
Yeah, we started a medication-assisted recovery anonymous group here at our clinic, and it's really going well. And before, some of my patients were going to the traditional meetings and they were told things like, you're not really in recovery and things like that. And they were receiving a lot of stigma, and it was really hurting their recovery. So we learned about MAR and started, and it's becoming pretty successful. That's all I have.
That's fantastic. Yeah. Yeah, and if anyone's interested in learning how to start one of those, Dr. Gorby, maybe you can be a resource for that. We had one here for a while, and because of COVID, we've never gotten it back up and running. But when it was running, patients appreciated it so much. It was like a safe place for them to come and be able to be honest about being on medicine. Yeah.
I think it's a kind of a slow transition among the recovery community. And certainly I've seen, especially in Morgantown, there's a lot more acceptance and understanding that this is a path to recovery as well. But I think too, helping to educate patients too, who might be experiencing some stigma when they go to meetings, and educating them on, okay, this is one person's opinion. It does not represent the fellowship or everyone there. And that can be helpful too, and just discussing with them how to approach the situation if they do face that stigma at a meeting, and recognize that, not everyone's going to agree, and that's okay, but this is what works for you. And really, 12-step fellowships have no opinion on outside issues, no opinion on medications. So those are just individuals. So if you can kind of help your patients understand that. The interesting thing you mentioned, stigma that providers face. I remember, so I was family medicine physician for a long time, ran into one of my former patients in the elevator at the hospital when I was doing my addiction medicine fellowship. And she's like, oh, are you back? I'm like, well, I'm not doing family medicine anymore. I'm training to do addiction medicine. And she was like, what? Why would you do that? And that was literally the response I got. And I was like, well, actually, it's really rewarding. But just being able to, and my family, same way. Why would you want to do that? So being able to educate family, coworkers, other people in the community, just like, it's actually, again, no different than any other disease that we treat. And it can be really rewarding, just like the person who has diabetes and follows all your recommendations and gets off their medications and does great. Addiction medicine can actually be really rewarding, but certainly they're going to be the ones that don't do well. And unfortunately, I think we tend to keep those in our minds more than trying to grasp on to the success stories like you talked about. Like that's what sometimes I can go through a day and be like, man, that was a rough day. But if one person said one thing or did one thing, then it was a good day. So that's all I got.
Yeah, thanks, Dr. Long. I both of those points about, well, it's actually three, like that it is changing in the recovery community. Like I've seen a change in the last 5 to 10 years, but we're not quite there yet. And helping to coach patients about how to sort of advocate for themselves, or at least sort of stand their ground and not feel like they're doing something wrong. I think can be a role that we can certainly play. And then your own patient, like former patient, like judging you, that's a good one. I hadn't heard that before. And then also our families, like my family doesn't know what to do with me, which is not news, but like I can't, I start to talk about work and their eyes sort of glaze over because they're like, it makes them really uncomfortable. So that's okay. It no longer bothers me, but for, when I was younger, it did bother me that they didn't really necessarily value what I did the same way as if, I might, if I were working maybe with a different group of folks. Yeah.
I was going to say something about, how society views people who have a troubled self in general. That I think we kind of, the cultural view is to kind of look down at people who are troubled. And I think if we believe in the ability to help these people, it kind of disempowers that tendency.
Right. And if you view people who have experienced trouble or have, troubled selves as potentially having resilience in the ability to overcome some of that trouble versus seeing it as a negative or a way to push them to the margins or discriminate against them. Yeah. So Dr. Morrison, no comments on the inroads you've made in your kind of primarily medical setting over the years, right?
So I will second the Mara support, and I would say that all of the progress I've made has mostly been thanks to you, Laura, and these stigma talks that you've given me over the years. And I've adopted all of the language changes, and that's really helped me. I adopted the language changes even before I believed in them, and then that made me a believer. So I would just tell everyone here to challenge yourself. Don't say clean and dirty, and see what happens with how you feel about discussing drug screens after that. It does change things. And so I'm really thankful for these stigma talks. I can't get enough of them. But more recently, moving to a higher level of stigma troubles where I'm like struggling to figure out the right balance with like are we overly destigmatizing actually bad behaviors in some cases? So it's it gets dizzyingly complicated when you have people like that are showing up high to your office, and now you're saying, well, I don't want to stigmatize you, but I need you to leave because you're behaving in a way I can't deal with. Is that being too strict? They could go home and die. Should I just let them stay and try to just chill them out and let them be their high? these situations, these more complicated situations of where I feel like, do I need to actually apply stigma to a behavior? I'm really struggling with still.
So Ryan, that sounds more like making a clinical judgment call as opposed to stigma, because what you're actually doing is reducing stigma if you address the behavior that has been proven to be, I guess, non-cathartic for a group. You know what I mean? If someone roll up in there at a group high and you ignore it and everyone else noticed it, it takes away from the group dynamic. It makes it look as if you're not doing your job. But if you were to address it and say, hey, this is not a therapeutic for this group, it makes other members of the group take it more seriously.
The other thing is if it's done in an empathic manner, I think that's the key. So if it's done in a hostile manner, it's going to be viewed differently than if it's done empathically.
Yeah, and I think it's also matching treatment to symptoms. So, someone can't participate in talk therapy or a talk intervention with other people if they are very paranoid and aggressive. And so that requires a different kind of intervention than talk therapy. And it's a symptom of their disease process, but it can't be treated in an outpatient group because it's not safe for the group, and they're not really going to get much out of it anyway. And so, looking at a different kind of intervention. And yeah, and the delivery is huge, huge in terms of the language and sort of the body language and how you respond to someone who's presenting in a way that's not safe for the environment and is not really a good fit for the intervention you're providing.
Yeah. In a past life, working in the emergency department, I felt ill-equipped to take care of people with substance issues. And I think as a response to that, I would get frustrated and defensive and angry, and I would act out. And I think there's probably a significant amount of that going on in our medical community, just not knowing what to do when somebody behaves differently than somebody else that we're used to. And so I think that's a challenge, is just educating people on how to work with people with substance use disorder. Some of the thing I found really helpful is some making people aware that there are also outside organizations outside of their little group. For example, the medication assisted treatment group that we heard about here, Faces and Voices of Recovery, is another great resource where you can just get just a broader perspective that there are other people out there that are healthy and other resources that are out there. In Massachusetts, I just sort of magically, serendipitously got connected with an organization there called Massachusetts Organization for Addiction Recovery, which has a very public face, is linked to Faces and Voices of Recovery, and had many, many public people on board with them, like the governor and the attorney general and Mayor Marty Walsh, who stands up and announces that he's in recovery. And so that had a really positive influence on people that were in the treatment community, because they would then learn about medication assisted treatment and that this was a good thing. And they would emphasize and teach people about non-stigmatizing language, which is just a work in progress. It's like you said, it just takes a while to kind of buy in or change the way that we verbalize these things. So, and I agree, it's like so many words.
Yeah, thanks, Mike. Faces and Voices of Recovery is a great organization. For a while ago, they put out a video called Anonymous People, and we would show clips of that in our groups when we still met in person. So Mithra, we should include that as a resource, but they have many, it's like grown since they put out that video. It's wonderful.
Absolutely. I'll make sure that's in the recap email.
I think the whole peer recovery coach movement, for people who remember the history of addiction treatment, it started as a peer treatment movement in the 60s and 70s, and then got very professionalized, almost like maybe too professionalized. And now there's like this shift back into peer recovery. And then with the emergence of addiction medicine and addiction psychiatry fellowships, which often, not always, but sometimes attracts people in recovery. I mean, it just creates this really nice blend of people with lived experience, as well as people with professional experience, as well as people with both, to help folks with substance use disorders. I feel really hopeful about the direction the field is going in. Obviously, with the opioid epidemic, we've gotten lots of press, not always good press, but it's shown a light on the problem, which creates an audience that we can try and educate. And there are very small ways that we can do it, language being the obvious example. So lots of tiny little ways we can combat stigma. Anyone else have any good strategies?
This is Jen Boyd. I have a little story about a small way. I have a colleague, a provider colleague, who, when I started getting into working in our MAT program, he flat out said he just didn't believe in it. And I talked to him about it. And then about a year later, and he still has a lot of stigma. One time he told me to be careful. He was nervous about me being a provider there. Anyway, about a year later, he came to me and he said, he was talking about I'm not sure what the context of the conversation was, but he said, I really see now that that medication-assisted treatment is really good for the society, because it's, it gets people back to work, and it gets them to be, to a place where they can take better care of their children. And it's really a good thing for, he kept saying, the society. And I said, and so I just said, it is, and it's a good thing for the individual too. And so, and his eyebrows sort of went up. And so there was just, it's an iterative process. I think these conversations with people over time, and having relationships with people where we also don't discount those with stigma, because as Laura said, we all have it, to use our experience to just to share what we know to be true.
Yeah, I love that story, Jennifer. And when those of us who work with people, and many of you guys do, like long term, get to see that shift over time of self-acceptance about the medication for many of our patients. And then they also become a story of hope and get more comfortable, sometimes even sharing their own experience with the recovery community or their families or whoever, so that they can become, that example of treatment works. And that's huge in terms of combating stigma.
I wanted to say something about Laura, you tied in the criminal aspect of substance use, and maybe just putting substance use aside and looking at criminal histories itself. That criminal histories can be very stigmatizing. And what Michael was saying about knowing examples of people who've kind of gotten past that and excelled in their lives, like Martha Stewart or Mark Wahlberg or Jay-Z, or some of these people who had criminal histories and substance use issues who evolved into incredible people. I think stories like that are good for some of our patients who may feel negatively about their past.
Absolutely. And also some of our peer recovery support specialists have sort of gotten into the workplace in the healthcare setting often and had to overcome some of, they do a background check. They're like, something's going to come up. I'm like, we expect something to come up. It's okay. And so we've tried to work with HR to help them understand something's going to come up and it's okay, which is, sometimes that makes HR nervous, but to be able to educate, the profession into, understanding that people get well and people change their lives dramatically.
I was going to say one thing. One thing that I've noticed that I think is important is if if you do come across somebody that you're working with, or somebody you know, somebody you respect that says something really out there, really bad towards it, I think it's appropriate to say something and talk to them about it. Not necessarily call them out and say you're wrong or anything, but try to educate them quickly. Because if you're quiet about it, if you don't say anything, I mean, really, you're agreeing with them. There's a quote. It's in Latin or something, but silence gives consent, right? So if you let them say it, you don't say anything, that's bad. So anytime I hear something, I usually try to talk to them and say, well, I don't know about all that. There's lots of people do well on medicines and kind of explain it, but that's actually helped, I think, just that at that personal level with nurses and people that I know, and has really changed the way a lot of people think. So it can be uncomfortable, especially if there's somebody you respect and maybe they're even above you or something, but it's not a good idea to just kind of let that stuff go if you encounter it.
Yep, advocacy, absolutely. You can do so in a professional and kind way, but not to be silent. I agree. So I just wanted to give a shout out to Tony and all the work that she's done to integrate her trainees into the world of addiction, and how much I have literally seen that impact stigma reduction like firsthand. I mean, because they'll talk about it. So that has been, I think, huge, and has a ripple effect through the entire healthcare system. Wherever those nurses go, they now view people with substance use disorders differently. So thank you, Tony, for all the work you've done in that area.
I see Derek clapping, so we'll copy him with that. We have about 4 minutes left. If there were any other comments or anything from the group. Alrighty, well, thank you. Oh, Tony, was there something you wanted to say? I think you had unmuted for a second there. Or maybe I'm seeing things.
No, you're seeing things.
Okay. I'm going crazy. It's definitely been a Monday. Alrighty, well, thank you all so much. Thank you, Laura, for a wonderful didactic and such an important one as well. And I appreciate all of you chiming in and sharing your thoughts as well. Dr. Gorby, was there something you wanted to comment on?
Yeah, I just want to shout out for the Pittsburgh Recovery Walk this weekend. I was there, and it really helps to reduce stigma. And there was hundreds, if not thousands, of people there. It's a great experience.
Wow, that's awesome. Thank you for sharing that. Alrighty, I will go ahead and launch the poll. Anytime you all finish the poll, you can go ahead and log off. Elizabeth, it might actually be on your end. It says it's disabled on my side. So if you can launch that, that'd be awesome. It isn't mandatory. So if you don't want to, you absolutely do not have to fill it out, but we will definitely appreciate that. The only announcement that I have is that our next session will be on September 27th, and Tony Dikiakio will be presenting on waiver obtaining. So keep an eye out for that reminder.
Thanks. Did it work?
Does everyone see the poll?
Oh no, you just frozen.
Me.
Or am I frozen? No. Did I freeze? Oh my God.
Marianne, did you say it was letting you submit it?
Yeah, it won't let you submit.
Huh, that's interesting. Okay, well, I apologize for that glitch. Thanks for letting me know that. We'll look into it for sure. Thanks, everyone.
Yeah.
Thank you, Laura.
Thank you, Laura.
Laura.